I bring you greetings from Ruby Hall Clinic from Pune, which is giving us more and more exposure to surgical and complex surgical procedures because of the cancer center that is coming up over there. The final outcomes of any complex surgeries or trauma patients would obviously depend upon the surgical skills or the basic injury, but equally they depend on the events that occur after the initial surgery and trauma. And that is where we as intensivists come in the picture. So the major role of multidisciplinary ICU would be to do the interventions to prevent complications and reduce the effects of complications. And the more and more we start evaluating it, the role of ICU starts even before the patient is taken for surgery from pre-operative optimization. I'm not going to spend much time on that because we are sticking ourselves to post-operative care. But you must have heard ERAS or Enhanced Rehabilitation After Surgery. And this program states the steps which are taken right from the before surgery or pre-surgical period, which equally applies to our high-risk or critically ill patients. So, multidisciplinary approach is what is most important. The surgical, anesthetic, and intensive care teams, plus all other supportive like physiotherapists and nutritionists and physiotherapy. It's extremely important. The death and serious morbidity are still common following major surgery, even though we are trying to be proactive in their management. Improved perioperative care of the high-risk patients will significantly improve the outcomes, and if you go through the literature search, you would come across very large number of papers which are talking about very specialized subgroups. For example, even post-cardiac bypass surgery ICU. We know how routine it has become about the post-operative management and picking up the complications early. Similarly, there are very large patient populations, specialized post-patient populations, so we cannot touch upon those in this talk, and we will mainly stick to the generalized approach, which includes certain specific points like pain management, prevention and treatment of infections, prevention and treatment of non-infective complications, dilemmas in special patient populations we will not touch upon right now, and nutrition has already been touched upon. We will see just one or two important points. So there are certain proven strategies which help to improve the post-operative outcome, like maintenance of normothermia, which itself reduces infection rate and shortens length of hospital stay. It reduces the stress of surgery, basically. Thromboembolic prophylaxis has been proven beyond doubt. Maintenance of good oxygenation and good circulation has been proven beyond doubts. And even early goal-directed therapy is equally applicable in post-operative patients. In other points of pain, extradural analgesia has become a cornerstone in all those post-operative patients where it is indicated. Perioperative fluid resuscitation, though a part of early goal-directed therapy, most important is what fluids we are going to use, and that includes balanced fluids, and we'll come to that. Early enteral nutrition has been emphasized good enough. In fact, in ERAS, there is a strategy not to keep patient NBM for a prolonged period, even before surgery. Till 2 hours before, the patient should be fed and patient should be given a carbohydrate load so that patient is in fed state when he goes for surgery, so that the insulin resistance doesn't occur. Early post-operative mobilization, minimal use of tubes and drains and catheters, and proper use of antibiotics and infection prevention. All this is going to help in reduced stress response, reduced organ dysfunction, and reduced post-operative complications. So clear fluids till 2 hours before sending the patient to OT, even in intra-abdominal surgeries. Send the patient in fed state, as I mentioned already, and it has been proven beyond doubt that it reduces infectious complications and length of stay when compared with nil by mouth strategy for the patients. In resuscitation fluids, the articles have proven beyond doubt that sodium containing, saline containing fluids are likely to give more chances of metabolic acidosis, decreased urine output and renal dysfunction, and increased coagulopathy as compared to physiological balanced solutions, which we are using as lactated ringer solution or balanced solutions with starch. Prevention and treatment of postoperative infections, and this is where a large number of patients would land up in ICU for. We are aware, and it goes without saying, can't be more emphasized, about hand washing and bundles to be placed in place for all nosocomial infection prevention. Prophylactic antibiotic. We still feel that prophylactic antibiotic is something that helps to reduce the rate of infection, but there is no evidence that more than one preoperative dose is required for prophylaxis during surgery or for any surgical procedure, except for certain exceptions. And that is where we are facing the major problems in postoperative infective complications, because in India, we are using large number of cephalosporins for large number of days and in perioperative periods. And that is why when these patients land up with postoperative infective complications, they are mainly multidrug resistant organisms. Commencing antibiotics much before the immediate preoperative period provides no benefit, and higher dose regimens are also no better than standard dosages. In high-risk postoperative patients, if and when they develop infective complications, we are aware that these are either healthcare-associated pneumonias or ventilator-associated pneumonias. Ventilator-associated pneumonias in ICU, when postoperative patient is there, almost comprise 70 to 80% of HAPs. We are aware that there is a new entity which has been recognized, and that is a precursor of HAP or VAP, and that is called as tracheobronchitis. It is hospital-associated infection where there is no new patch in the lung, but still we have to treat it vigorously so that it doesn't lead further to hospital-associated pneumonia. In VAP, again, we are aware that there are early and late stages. We will talk about it shortly. Soft tissue and skin infections is one of the specific subgroup post-operative infections would comprise of, and CRBSI or catheter-related bloodstream infections, which would be leading to septicemias. Unfortunately, when we start searching the literature and we start asking ourselves, we find that India has the highest burden of ESBL producing organisms. And that is because we are using cephalosporins excessively. The important dilemma facing the clinicians is the fact that extended spectrum beta-lactamase may not always be detected in routine susceptibility tests. So it makes us or catches us unawares when we come across post-operative infections till the time we start getting clinical results. Only the laboratory results are not going to tell us whether in vitro susceptibility is what is going to be converted into in vivo susceptibility. And this list of MDR microorganisms or ESBL secreting pathogens which are of concern for us in India. To add to that, we all are aware that New Delhi metallolactamase or NDM1 Klebsiella or E. coli has become a superbug because of infections caused by them are very difficult to treat, and such bacteria are usually only susceptible to polymyxins and tigecycline. So, in a nutshell, what we are facing in post-operative patients is the multi-drug resistance or pan-drug resistant organisms. So, in a patient who lands up in ICU unexpectedly after a post-operative infection, it is a great challenge for an intensivist to decide what antibiotic to choose. Most of the times they are gram-negative, so the choice of beta-lactam or cephalosporin plus beta-lactamase inhibitor combination is the drug which we have to choose. But which combination to choose and on what we are going to make our decision? Are there any real differences in these combinations is what we should look at. There is not sufficient data, but whatever data is available, we can see that there is very large incidence of all these gram-negative organisms in India. The impact of ESBLs on antibiotics is that most cephalosporins, which we are using in perioperative period as prophylactic or preventive antibiotics, are of no use in this situation. And that is why the choice of beta-lactamase inhibitor combination is crucial for treatment. And there are various types of beta-lactamase inhibitors available presently. We have been using sulbactam and clavulanic acid, and tazobactam has started coming in a big way. So how do we choose? How do we decide which combination to use? And when we compare all these three beta-lactamase inhibitors, we can see that tazobactam probably has broader spectrum. Inhibition of cephalosporinases is better by tazobactam. It does not induce cephalosporin destroying enzymes. Activity against the beta-lactamases from aerobes, such as bacteroids, also is quite good with tazobactam, whereas sulbactam is not as good. And activity against respiratory ESBLs also is very high. Activity against ESBLs from gram-negative bacteria is very high. So, given all these observations, the combinations which contain tazobactam perhaps have a better effect while we are dealing with post-operative infective complications. The in vitro activity, we have already seen that tazobactam has better activity against all types or all classes of plasmid-mediated beta-lactamases. We can see organism-wise and their resistant genes or beta-lactamases. Still, if we compare all these three beta-lactamase inhibitors, the likelihood of tazobactam being more effective in combination with a beta-lactam are higher. We can use tazobactam in combination with cephalosporins as well. By doing this, we are trying to preserve higher beta-lactams from penem groups as a last resort or keep it for very severe infections. Resistance to cefoperazone sulbactam was a very good combination which had been useful, but nowadays we have started getting resistance in tertiary care centers, which is being observed. Up to 34 to 40% resistant rates have been reported in gram-negative bacteria for this particular combination. So let us see in our market or for us in clinical use, what are various combinations with tazobactam are available. And piperacillin tazobactam still remains a forte in the management of hospital-acquired or post-operative infections. For the organisms which are becoming more pan-drug resistant or MDRs, extended drug resistance, then of course, if the clinical status is extremely critical, we have to go according to the first choice of penems in this group. We have been coming across ventilator-associated pneumonia, and we are aware that early and late would have different types of propensity towards organisms, and that helps us to choose the antibiotic as well. In early onset VAP, which occurs within 4 days of endotracheal intubation, gram-positive strep pneumonia or gram-negative E. coli and Klebsiella are quite common, whereas in late onset, MRSA or gram-negative Enterobacteriaceae pseudomonas and Acinetobacter, which is increasing like anything in Indian ICUs, is more common. And when we are taking it into account, whether it is early or late, it will again help us to choose the correct antibiotic. There is something described by Kolev in his article as PARGNB, that is the organisms which have got propensity to develop resistance to gram-negative pathogens. Since we are using pre-operative antibiotics in more haphazard way, which we have to accept, there is a chance that these potentially resistant organisms would overgrow, and we are likely to face these organisms as MDR organisms, which are shown in this list, in our post-operative infected patients. So the choice of antibiotic therapy and impact on mortality, we are quite clear and we are quite convinced about by the articles, various articles of Kolev, that initial appropriate antibiotic therapy is most important. If you are starting with a trial antibiotic and because of lack of response, you are escalating the initial antibiotic regimen, both of them would be associated with greater mortality. Now, in this given scenario, choosing an antibiotic is a very, very important job for an intensivist while managing post-operative patients in ICU. This particular graph shows us how inappropriate initial antibiotic therapy reduced the survival significantly. The impact of inappropriate initial antibiotic therapy also has been shown negatively in patients with bloodstream infections or severe sepsis in post-operative situations. Not only that, even in community-acquired infections, inappropriate antibiotic therapy in initial period is equally worse as far as the mortality is concerned. And so with this, I think in post-operative patients who are emergently admitted in the ICUs because of infective organisms, we will have to go with de-escalation of antibiotics. And that would include very high beta-lactams or combinations of cephalosporins with beta-lactams, which have proven to be useful in this type of infections. Skin and soft tissue injuries after surgery are not uncommon. Most of the times, if they become complicated, Staphylococcus aureus is the commonest cause, and the toxin production, particularly with PVL, may complicate SSTI, and which is a particular enzyme which causes extensive tissue necrosis. So PVL secreting MRSA are resistant to vancomycin. Even though as compared to West, our incidence of MRSA is less in our own ICUs, still it is not unknown, and we have to be very, very careful in treatment of SSTIs to follow the cultures regularly. Even before that, prevention of MRSA and the staff surveillance is extremely important in operation theater areas or all the staff who is working in surgical patients. The mainstays of treatment of SSTIs, even though they are penicillins, cephalosporins, and clindamycins, since the resistance in gram-positives also are on the increase, it is more important for us to consider beta-lactam, beta-lactamase inhibitor combinations in this subgroup as well. If they are really resistant MRSA infections, linezolid, daptomycin, and tigecycline are useful. Of course, on day one, we are not going to know whether they are going to be resistant organisms, and even de-escalation therapy is important in SSTIs if they are quite significantly bad, quite significant infections. In post-operative management, post-operative pain management in perioperative period, that can be one of the most important causes of giving cardiac complications. Pain can decrease alveolar ventilation and increase respiratory complications, and it can also lead to poor wound healing. There are some new concepts and new interesting facts coming up in post-operative pain management. Continuous epidural analgesia in selected group is extremely important, and along with epidural analgesia, we can even early mobilization of patients we could achieve. Opioids, which were used as analgesics, are they really helpful, or they increase post-operative pain, or whether they increase the duration of post-operative pain was a question raised with recent observations. And it has been shown that opioids do induce hyperalgesia because opioids can increase rather than decrease the sensitivity to noxious stimuli. Opioids can activate pain inhibitory as well as pain facilitatory systems. This pain hypersensitivity has been attributed to a relative predominance of pro-nociceptive mechanisms. It can even increase the long-term pain sensitivity in post-operative period. So even in this ERA's recommendation, that is early rehabilitation in surgery, after the surgery, opioid use has been discouraged. It is not recommended to use opioids in post-operative pain management. Why does that happen? It's probably because of activation of these receptors, NMDA. This receptor system causes winding up or increasing the threshold to pain. NMDA receptors, when they have been recognized, can we modulate NMDA receptors was the question, and whether we can block the winding up or upregulation of pain receptors was the research topic. And there has been some new molecules. There have been some new molecules which have come up for postoperative management, like flupyritin. This has been found to be very useful in postoperative pain management, which is a potent non-opioid analgesic drug. It has similar efficacy as opioids. It can raise the pain threshold as well as it is well tolerated, and plus it has no abuse potential. It has been compared to current conventionally used analgesics like tramadol and diclofenac. It provides rapid onset of analgesia within 30 minutes. It reduces central pain sensitization, raises pain threshold, and prevents the development of neuronal memory of pain. And in these various studies, you can see that the patients did have higher satisfaction scores for pain management as compared to tramadol with this new molecule, flupyritin. It was a better tolerated drug than tramadol with lesser side effects, nausea and vomiting. There have been studies where flupyritin has been compared with diclofenac as well, whereas the speed of analgesia also was quite satisfactory. Two previous talks have addressed well enough the issues about nutrition in critically ill patients, but as far as this particular subgroup of post-operative patients is concerned, it is quite evident by various studies that surgical patients are much malnourished as compared to medical patients in the ICUs. Surgical patients were less likely to receive enteral nutrition, and overall calorie deficits were much more in post-operative surgical patients. So these patients receive less nutrition because of various reasons. Still, our conventional understanding of keeping the patients nil by mouth for a long time, but a lot of recent studies, even in colorectal surgeries for quick rehabilitation, show that within hours of post-operative period, you can start them on low residue enteral diets as well. You can feed them directly into jejunum if you are doing higher upper GI surgeries. The strategies to improve nutritional performance, including protocols as was shown in previous two studies, is highly recommended in this particular subgroup of post-operative patients in the ICU. And we cannot close without having a word about glycemic control. The surgical care improvement has been benchmarked at 6 a.m. blood sugar on post-operative day 1 and day 2 less than 200 as an indicator of overall glycemic control. So even though we try to achieve the levels between 140 to 180, immediate post-operative day, the benchmarking was done for glycemic levels below 200. But in observational studies, it was shown that only 10% are compliant with this benchmark. So we are still not achieving enough glycemic control. The tight glycemic control has been discussed time and again. It has shown that very tight glycemic control is of no use. It can actually worsen the outcomes even in surgical patients because of incidence of hypoglycemia. But the newer recommendations of maintaining blood glucose targets near 140 are to be followed, and which can be achieved in highly unstable surgical patients by continuous IV infusion of glucose, or in patients who is improving, subcutaneous basal and bolus insulin regimens can be very useful to reduce the variability of blood sugars in post-operative patients. It can be supplemented with corrective doses as needed and adjusted daily with guidance of frequent blood sugar monitorings. Okay, prevention of hypoglycemia is one of our important goals. So with this, I think we have largely covered common topics or common points for post-operative management of high-risk surgical patients. Improvement in outcomes of high-risk surgical patients is a success story of modern critical care medicine, and which is a real example of multidisciplinary management of a patient. Thank you.